Good afternoon, everyone. Happy Monday to you. For those who don't know, today is Paul Revere Day, just in case anyone wanted to know. Let's see, announcements. If you didn't get like your discussion board or your assignment turned in or whatever, everything from this last week, you have until Wednesday to get that turned in by 11:59 p.m. There is no quiz today. We're going to go over chapters 12 and 13 this week, and then chapters 12, 13, 15, 18, and 19 will all be part of your midterm next Monday. So let's just jump right into it. Chapter 12. Chapter 12 is pharmacology. Even though we don't get to administer medications, we will still do some mixing and preparation of those medications on the field. So we do need to know how these affect the body and some of the more typical drugs and things that we use in the operating room. But pharmacology itself, it's just the study of drugs, what they do to the body, what the body does to the drug, all those kinds of different things. Some of the origins are how medications are made, right? You can like synthesize a chemical. You can derive them from like human or animal proteins, minerals in the earth and elements, things like that. And then also from plants. A lot of our antibiotics and things like that come from plants. So some of the metals would be like salt that we use like in the saline, barium. We use that as a in X-ray to be able to see structures and things like that and see the flow of um, of fluids and things like that through tubes and uh, intestines and things. Sorry. Some of the resources that we can find information on these particular medications and things that we use. The PDR, the Physician's Desk Reference. Some of you who have been working on your project have already accessed this and see that it has just a plethora of information in there. But a few other places that you can go is like the hospital formulary for the particular each hospital is supposed to have their own formulary of, and it's the list of medications that they have at the hospital. But there is also a standard like book for the country that for the American Hospital Formulary Service, where you can. It's kind of like the PDR, just a different. It's just a different book, and then you have the Pharmacopoeia. It's kind of like an encyclopedia of all drugs, and then of course the FDA themselves that you can access their website and look up information on any kind of particular medications and drugs and stuff that we use in the hospital and clinical settings. Typically for us, we use the PDR. Each OR has a kind of like a mini library where you'll have like a PDR, you'll have like a nurse's book, you'll have a few kind of like medical books and things like that that you can reference if you need to. Regulations on these drugs, right? You have, laws and also institutional policies by the hospitals themselves. And they'll cover things on, like the proper handling and storage of them, how they get administered, right? Does it have to have, is it an over the counter drug? Is it a prescription drug? And how are we going to give it to that patient? Is it an oral medication? Is it a, IV? Uh, is it intramuscular, sublingual, buccal, those kind of things? We're going to go through all those different routes of medication. But the regulations typically cover a lot of this as far as, where you're supposed to keep it in the hospital. Is it supposed to be kept under lock and key? Is it a narcotic? It's, some of it also depends on the category of medication it is. If it's a narcotic, not only does it have to be, like locked up, but it has to be under like double lock. And two people, two nurses or two licensed professionals are the ones that pull it out and count how many are in there and things like that, just as a secondary kind of precaution, so that no one person has complete control over the narcotic medications, so they can track and make sure that what's supposed to be there is there. The FDA has their own regulations. A lot of it is their regulations also deal with like the handling and things like that. But it's also more along the lines of if it's safe for human use and kind of things like that. Is it, are there very specific uh, precautions and things like that have to be taken? You know, uh, prescriptions, over the counters. Is it a food supplement? Cosmetics, right? A lot of this stuff has like chemicals and things in it uh, that the Food and Drug Administration has to approve for them to be used on humans. Um, medical devices, anything that you could have medications that are deliver radiation. We have, and those have to follow very specific guidelines and things like that too, as far as their storage and handling of, and what to do with them after they've been used, how to dispose of them, things like that. So, but then also notice here, we're not talking about just medications the FDA has to deal with. We're also talking about suture. So the FDA is in charge of the regulations regarding sutures as well. The wound closure materials, it says here. Some of your different types, right? You have prescription and over-the-counter medications, right? Prescriptions, a doctor has to write you a note that they sign, and you take it to the pharmacy and hand it over to them, and they verify it and all that stuff. Over-the-counter stuff, that's the stuff you can just go to the store, like aspirin and Listerine and Benadryl. Those kind of things are available just over the counter. You can go and pick that off the shelf, take it to the cashier, and nothing has to be double checked. Then there's the controlled substances or narcotics. Um, the reason they're controlled is because they carry that high risk of abuse or addiction to them, right? And then you have 5 different schedules of these drugs. Schedule 5 being the least uh, likely for addiction or abuse. Schedule 1 being the ones that are the most addictive and things like that. But each one of these and drugs in each one of these categories, we do use in the hospital and in the OR. So it's why we have to keep them kind of under lock and key and have the 2-person verification kind of thing, just to make sure that no one's like sneaking them out or, uh, abusing or becoming addicted to these substances. Then there's also pregnancy categories. A, B, C, D, and X. It means that if you handle these medications based on what category it's in as far as the pregnancy component, is it may cause harm to your fetus. And if it's a D, like A, B, and C, C is like a probably not a good idea to take it, to take it or to even handle that medication. A and B, there may be some risk, but depending on what the patient has going on, it may be a minimal risk compared to if they didn't do anything for that patient. X is absolutely not, will most definitely cause harm to that fetus, cause harm to the fetus. There's even certain drugs out there, especially the ones with like the X category, that you can't even, like if it was a pill, you couldn't even let that pill touch your bare skin because you would start to absorb some of the medications through the skin, and that could harm the fetus in that regard. So um, we categorize them that way. That way, if someone's pregnant, we know, okay, they can't have this. We have to find an alternative to this particular medication. And then, of course, you've got kind of your home remedy type stuff, and your food supplements are in their own separate category. Basically, if it's a GNC, it falls into that category: herbal remedy and food supplements. Now, naming our drugs, right? Identifying them. There's 3 different names, right? There's a generic name, the trade name, and then a chemical name. Generic is usually cheaper than your brand name or your trade name ones. Benadryl is a trade name. The chemical name is the actual like chemicals that are in it, like let me try to think of one. It would have like all the elemental names and stuff to it. It'd be like it's not a medication, but carbon dioxide. That would be the chemical name. It's telling you the actual chemical elements that are inside it, that are in that medication. The trade name, like I said, Benadryl, and then you can have generic. Benadryl comes in like a black and white box or whatever, and just says like allergy medicine or something like that, right? Um, for your like aspirin, aspirin is the generic name. Tylenol is the trade name, or like Bayer aspirin. So those are your trade names. Aspirin is its generic name. And then its chemical name would be acetaminophen, or actually what's in uh, aspirin. Drug labeling, right? This is what you read on the label on the outside of any bottle, pill bottle or anything like that. It'll tell you like its dosage form, right? Is it a pill? You have to take it by mouth. Is it topical? You just put it on the skin. Is it uh, if it's oral, then it could be in pill or it could be in liquid. Something you have to drink, right? Things like that. On the label itself, you'll have the name of the drug. Usually, the trade name and the generic name will be on the label. Its dosage form, oral, uh, buccal, those kind of things, sublingual. How many you have in the package, or how much, if it's liquid, how much liquid, how many ounces. The indications, what are you taking it for? Right? The dosage, how much is it? Is it 20 milligrams? Is it 100 milligrams? Is it, uh, 1 gram? That's your dosage. Right? Contraindications. Is there a reason why you shouldn't take this medication? Do you have some other disease process or comorbidity going on that says if you take this medication, you're actually going to get worse? The lot number, right, and the expiration date of the drug. The lot number is just in case they have a lot of patients who are experiencing like side effects or uh, real bad adverse reactions or something like that, and then they can track it back to that lot number and see if the same thing is happening to a lot of patients from that particular lot number of that lot number of medication. And then the expiration date, if you start taking the medication past the date is expired, it's not going to be as effective because these medications have what's called a half-life, which means there's a certain amount of time, and each element on the periodic table has its own half-life. But what it means is that's the amount of time it takes for half of that particular chemical or element to half itself. Because things are always, breaking down in nature. So that's the amount of time it takes it to half itself. And that's usually what they base the expiration date on. Well, if you start taking it when it's only now half effective, you don't know how much to take. You know what I'm saying? Like, I took this one pill. It only took my headache away for like half the time that it would normally do it. So should I take 2 pills the next time to equal the one that it was before? Tough to do because you don't know, maybe this one hasn't fully met its half-life yet. So it may be a little bit more effective than you're counting on. And with aspirin, it may not be that big of a deal. Trying to take away a headache, okay. But now we start getting into, giving medications for patients, like anti-hypertensive medications and things like that. And if we start over kind of dosing them a little bit, it may have a residual effect or a bad effect later where we think we're controlling their blood pressure, but we're not really. Drug errors, right? We want to make sure we've got the right patient, right? Make sure we've got the right drug. We're checking that packaging and that label that's on there to make sure that we're matching it up to the order that the doctor gave, right? There could be, you could have the wrong patient or you didn't double check the patient's ID band and things like that. You may have misread the order that was given, right? You may have misread the label, or the label was printed incorrectly, right? There could be other environmental factors going on. You're, extremely busy between, breaking down and setting back up and stuff like that, and you're hustling and everything, and your nurse calls out the medication and shows it to you, and you glance at the bottle real quick, and you just repeat what you thought you heard, but you didn't really read the label. Right? Drug devices, right, like pacemakers and things like that. You may have, they open the wrong one to you, something like that, right? So we're always double checking before any packages of an implant or something like that gets put in. It's always shown to the doctor or to the tech, right? And okay, this is the right size. This is the one he wanted, and then it gets opened. It's always like a double check thing to try and prevent, these errors. How competent is the staff? Do we know that this, particular implant or this particular drug shouldn't be being used in this situation, or those kinds of things? We're not always, and some of the complaint I hear from, especially like other techs, especially experienced techs, is that why are you asking me how much medication I should give? You're the one who went to medical school. Shouldn't you know that? Yes, they should. But the reason we know all this stuff, and so it's so that we can be a double check. We can be that safeguard in case. Right? Places to think about where a drug error might occur too is nurses and doctors and stuff, when the patients are getting discharged from the hospital, they provide them with a lot of education on the medications they're going to be taking at home and things like that. And it's all coming at you real fast as you're trying to leave the hospital. Right? So you don't know that, patients always aren't going to remember all that stuff. And that's why we make sure we send them home with that same information we gave them in written form somewhere so that they can read back on it. We give them the ability, that they can call their doctor, they can call back up to the hospital and get, clarification on certain things that they're supposed to do and stuff like that, trying to prevent, these errors and stuff like that. And then we're always going back and checking on how is our process doing, right? Are we doing what we're supposed to be doing? Is it working like we want it to work? Is there something else that we can do to make it a little bit better? I kind of brought this kind of the same point as far as the school goes, when you guys are at clinicals, we're instituting with the class that's out there now, kind of a system so that the preceptors and the hospitals out there can know what stage in training the student's at. And we did that by like a color code thing. But and we have about every 6 months or so, we have what's called a PAC meeting with all the clinical sites. And we go out and we talk with the preceptors and with the doctors and the nurses and stuff like that have you guys out there as students. And we talk about, how is it going, things like that. Where do you think we can improve? And one of the suggestions was this kind of color coded system of red, orange, yellow, and green. Red being, you need to be watched. Like you're relatively new. Everyone pretty much for the first week or so will be designated as a red because you're a new student out there and they need to kind of walk you through things. And then as you do cases and you get evaluated, we take those evaluation sheets, look over them, see how you're doing on that, and then we'll upgrade you in terms of your color as you move along. Green meaning that you're good to go. You need very little supervision, maybe some guidance with procedures that you haven't done yet. The reason I bring that up is we do the same thing in every process that we do in the hospital, not just in the OR, but the hospital wide, is that if somebody comes up with a plan or a process on how to do something efficiently and effectively and things like that, they implement that plan and then they will go back every so often and check to see how is that process working. And that's that quality. We're doing a quality check and we're seeing if there's any risk parts that maybe we didn't think about, things that have come up that we need to deal with. Maybe we can tweak our plan a little bit in our process to make it smoother and better for everyone. Now, along with that, there's the rights of the patient, the 7 rights. So you have to make sure you've got the right drug, the right patient, the right dose, the right route. It's the right time to be giving that medication to that patient. Because some things, you take, like 4 times a day or twice a day or something like that, once in the morning, once at night. If it's 2 o'clock in the afternoon, it's not time for that patient to get that medication yet, right? The right indication. That's the reason why we're giving the patient that medication. Is the medication we're going to give them going to take care of the problem we're giving it for? And then the right documentation. In our case, for the surgical tech, that means we're labeling all the containers that we have on our field that has that medication in it. One thing to keep in mind is that even though your saline is for irrigation, it is still considered a medication. So you still have to label the pitcher and you have to put a label on the asepto syringe when you fill it. When you have your local on your table, those little cups that come in your basins, that's what the local is going to get poured into. You have to put a label on that cup. And also when you draw it up into the syringe, there must be a label on the syringe as well. And those labels, you have labels in your basin and your skin marker, you're actually going to write out what the medication is. You need to put the name and the strength of the medication. We're going to practice this in lab, and I'll show it to you and stuff like that. But it's like if you have 1% lidocaine with epinephrine on your label, you're going to write 1% lidocaine with epi. And that's the label that goes on your cup, and that's also the label that will go on the syringe. But know these rights. There is one right that is not listed here. It is the patient's right to refuse. The patient has the right to refuse any medication, even if that medication is going to save their life. They can say, I don't want it. The classifications. So there's some drugs that kind of look alike and sound alike. They've made kind of a list of those. Each hospital is supposed to have their own list of those that are kind of look alike, sound alikes. The reason we do that is so that we don't accidentally mix them up. Use one instead of the other one. I'm trying to think of one that's sounded like look-alike. In the OR, I mean, some of them, like a lot of your medications and local and stuff, they're all going to be clear fluid. So that's why it is so important to label your cups and things that you have stuff in, so you know exactly what's in it. I had an ENT surgeon once. He in ENT, whenever you're like working on the nose or something like that, you're going to have a separate tray that gets opened up on the nurse's like prep stand. It's called a local tray. All it is just a small like little metal tray. It's got some sponges in it, a few medicine cups, some towels, nothing real fancy or anything like that. You'll open up a syringe and a needle, or a couple of syringes and needles to that field, and it's all the stuff that they do to kind of pre-op before we actually prep and drape out the patient and actually start the surgery. They're going to inject local into the nose, and then they'll also put some Afrin soaked sponges into the nose. That Afrin dries up and kind of like constricts the blood vessels in there, so you don't have a whole lot of bleeding while we're working. But we have to put all that stuff in and let it kind of soak in the time that it takes, the doctor to go and scrub and get gown and gloved and us to drape and stuff like that. Then they pull them out and we can do the surgery with a lot less blood in our field. Well, I had one surgeon, he liked to clean the face with alcohol, and he didn't need a whole lot. So he wanted one of the med cups filled with alcohol. And the other one's got the Afrin spray in it with a couple of sponges. And then your third one's got your lidocaine for your local. Well, he was injecting the nose, and he had used everything that he had in a syringe. So he took the hypodermic needle off and went back over to the med cup and filled it up, put the needle back on, and was going to inject when I noticed that he pulled from the cup that had the alcohol in it. And I stopped him before he injected rubbing alcohol into the patient. And I'd let him know that, hey, he grabbed the wrong one. I got a new syringe and needle and all that. But each one of my cups was labeled. He just didn't read the label. He just stuck his syringe in there and pulled up. So we got to be on alert for those kind of things. Right? These high alert medications, these are ones that have been involved in a lot of errors. So they made those now a priority. The one I can think of the most is heparin, because heparin always has to get mixed up into like saline and things like that. So math errors is what usually happens. You end up putting in either too little or too much of the heparin into the saline, and you don't have the right kind of dilution. We got to know about maximum doses because we have to know, like if the surgeon injects 30 cc's of local, and then at the end he wants to inject more. Well, some of that's dependent on patient weight and things like that. So there may be only a certain amount more that they can give. We may have poured 50 cc's up to the field, but because based on the patient's weight and stuff like that, they can only take 40 cc's. So we have to be able to know that and let the doctor know. Like no, just give me the rest of it. You're like, well, you already gave her 30, and she can only have 10 more. And then the surgeon turns and has a conversation with anesthesia. But we're just letting them know, hey, that's an unsafe dosing. And then they can have a conversation with anesthesia, and then now it's two doctors coming to a consensus. On the prescription, you must have the name of the patient, the name of the drug, the strength of the drug, the dose, right? How many, right? The route that it's going, and then how often that patient is taking that medication. For us in the OR, usually it's going to be some kind of local anesthetic. The route will be sub-Q most of the time. And the time and the frequency is right now and no, and then as needed or PRN. These are the types of orders that can be given. It can be a verbal order. The doctor tells you, hey, I want 1% lidocaine with epi. That's a verbal order. Written orders, they actually write it in the chart. The standing order is they gave that order like one time, like, say for this particular procedure, I always want to use 0.5% Marcaine with epi. Okay. And then it goes on the preference card, and now that's what's considered a standing order. He doesn't have to say it every time. He doesn't have to write it every time. It's already understood. A stat order is right now. Need it right now. And then a PRN order, PRN means as necessary. So whenever the patient, usually the pain medications are given on a PRN basis. When the patient starts to feel pain, give them this medication. And then some of the other times, excuse me, but the pain medications is that they'll prescribe something that's given, as every 4 hour, every 6 hours, or every 4 hours, take one of these kind of pain, like a Tylenol or something like that, or ibuprofen. And then they'll have a backup order for like, a morphine or a Percocet or something like that. And those will be PRN orders. So if the pain is too much for the aspirin, then you can use this instead. So for getting and giving drugs, right, dispensing and receiving, you want the appropriate size container, right? If you're giving me 50 cc's of local, I'm not going to hold out a cup that only holds 30 cc's, right? Because I want all 50 of that. The circulator, what's going to happen is the circulator will hold the bottle, and they're gonna hold the bottle, read it out loud to you, and then turn it so that you can see the label. And then as the tech, you're going to read that label out loud as well, kind of repeating what the nurse just said. You're both checking the integrity of the outside package of the medication, right? And then the circulator is going to pour that either in, if it's saline, they're going to pour it into your pitcher. If it's local, they'll pour it into your cup. Right? Like I said, all containers that fluid's going to be in has to have a label on it. And then once you go to pass that syringe and needle to the surgeon, the first time you pass it to him, you're going to call out the strength and name of that medication. So if it was 1% lidocaine with epi, as you're handing them the syringe with the needle on it, you're going to say 1% lidocaine with epi. Okay. And that's another verification that they know what medication they're about to inject. They know what it's going to do, that kind of thing. And then if it's not something that they wanted, or maybe they didn't want this particular time, they didn't want epinephrine in it. And they had told the circulator, but the circulator forgot to tell you and had kind of forgot about it when just pouring it up to your field. They were just kind of in a hurry. And he's like, oh, this says epi? Yeah, I need a plain. And they'll just hand it back to you. You get rid of all of that, and then the nurse has to go get you a different medication that doesn't have epinephrine in it. And you go through this whole process again of them calling it out to you, letting you read it, pouring it up to you. Then you draw it up at the syringe, hook the needle back up, and then you'll tell them, okay, now this is 1% lidocaine plain without epi. That's how we say without epi. We just say plain. That way it's not, there's no confusion. You're not saying 1% lidocaine without epi. And they're like, oh, does this have epi in it? Because they didn't really hear if you said with or without, with or without. But if you say plain, then they know no epi. We just went through all this, right? Both the surgical tech and the circulator are responsible for these medications getting to the field aseptically. One other thing, anytime you're pouring, whether it be local or your irrigation onto the field, once the pouring stops, or once the pouring starts, if it stops, like it's no longer coming out of the container, but there's still fluid inside of it, you cannot just now start back up and continue pouring. You pour the entire contents of that bottle out. If you stopped and came and there was some left, then that just gets taken away. You don't get to put that up on the sterile field anymore. It's just wasted. And then you never recap the bottle with the intention of pouring the rest up to the field later. Once you take that top off, I think you either pour it all up there or it goes in the trash. Glass vials. These are like the ones that you see in lab. They got the rubber stopper inside. The safest way is for the nurse to put a needle with a big enough syringe to take everything out of that and draw it up in the syringe, and then squirt that out of the syringe and onto the field. What you're going to find out there is that they just pop the top off of those little bottles and pour onto your field. There's been some kind of controversy and discussion about because when you go to take that rubber top off, you're kind of rubbing all around that edge, and then when you pour, that fluid is going right over the area you touched. So, and the reason that people are still hanging on to it is because it's the way they've done it forever, and no one wants to kind of give up something that they've done forever, kind of thing. So, you notice here it says never insert a needle into a vial held by another person. Why not, would you think? If you think about it, you got one person holding the vial, right? And then you have another person coming at them with a needle. What happens if they slip?
May poco.
Right? You can stick that other person. Not good. Not good. Glass ampules. So those are little bottles, and you can pop the top off, and you actually break the glass, and that's how you open it. You want to open those using a sponge, so that none of those glass shards, stick into you or come flying up at you and stuff. It all stays contained within that sponge. When you go to withdraw the fluid out of those vials, you need to use what's called a filtered needle. It's only going to allow the liquid to come through and not any little tiny particles of glass that may have fallen into that liquid when you pop the top off. And then once you have it in the syringe, now you can squirt it onto the sterile field. There are still some of these out there. We hardly ever see them on our field or getting used on our field. Most of the time you see those, anesthesia is dealing with them. Epi comes in those glass ampules, but it's just epinephrine by itself. So you may see the circulating nurse use those to inject into the bags of saline that we use for arthroscopies to help keep bleeding to a minimum. Reconstitution. We do have some medications out there that come in powder form, and we need to use injectable saline to get them back into liquid form. Bacitracin and thrombin are two of the bigger examples. Bacitracin is an antibiotic, and once we reconstitute it and turn it back into liquid, we add it to our irrigation. So now we have antibiotic irrigation. Thrombin is a coagulant, but we have to, it comes in a little powder, and the nurse has to kind of mix it and turn it back into its liquid form. The thing with thrombin is we never, ever, ever, ever inject thrombin. Thrombin is always given topically, which means it's just set on top of something. Because thrombin will start your clotting factors. So if you inject thrombin into the vascular system, you're going to end up with clots throughout every blood vessel in your body and then die. Irrigation, saline. We can also irrigate with water, just regular water. We'll talk more about that, the hypotonic, isotonic, and hypertonic solutions. But we need to maintain those and keep them like in a fluid warmer so they're the same temperature as the body. And then, like I said before, all or the entirety of that container, the bottle of saline, should be poured up to the field in that one time. Measurement systems in pharmacy, right? Typically we use the metric system in the hospitals, so that way it's uniform everywhere. No matter what hospital you go to, those units should all still be the same. The apothecary units, these are like, drops. What are some of the other ones? Like ounces, pounds, things like that. All time gets written down in military time. For those who don't know military time, basically the morning is easy, right? You've got 100, 200, 300, 400, all the way to noon, till 12. And then everything in the afternoon, if you just subtract 12 from that number, that'll get you. So like 1300 is 1 o'clock. You subtract 12, 1 o'clock. Right? 1400, 2 o'clock. Or 1500, 3 o'clock. Right? It just keeps going up that way. The the metric system is commonly used in every country except the United States. But we still use it in the hospitals for that uniformity. Remember your little prefixes, right? Kilo is 1,000, hecto 100, deca 10, deci is 1/10, centi 1/100th, and milli 1/1000th. These are the ones you'll see most often. The like kilo, you'll see it in like kilograms for unit for weight, but then you'll hear like milliliter. What's the other one? Centimeter for height. More metric system. Your apothecary stuff, right? You got like Roman numerals. I is 1, V 5, X 10. See how it kind of matches up here? So M is 1,000, D 500, C. These are our delivery devices, right? The things we're going to use to actually administer medications, right? A syringe, right? And there's all different kinds of types and sizes of syringes, right? You have like 1 cc, 5 cc, 10 cc, 30 cc, 60 cc syringes. The needles, these are going to come in, their sizes are going to be gauges. That's that GA or just G. You shouldn't just see a G because that means grams. So it should say GA for gauge. Next, if you see it in writing. But the bigger the number, the smaller the diameter of the needle. So like a 30 gauge needle is very small, almost like just a pinhead in diameter. Whereas like an 18 gauge is pretty big in its hole. 18 gauge is what you usually use to draw up medications out of a vial because it's got the biggest hole to it, and it's kind so you'll be able to pull a lot more quickly. But you also have like TB syringes, tuberculin syringes. Those are usually like your 1 cc syringes. And then you also have a very specific kind of syringe called an insulin syringe. The insulin syringes are a little bit different because they have both the insulin units on the outside of it plus the millimeter number. So the dosaging for insulin goes by units rather than like cc's or milliliters. So that's why there's that special syringe for insulins. But we have like IV tubings and like stopcocks, so we can start and stop the flow, or we can kind of control the flow of fluids and things like that in. You have infusion pumps where you can program it to that way, with the stopcock, like if we're trying to control how much medication is going in and stuff like that, then we have to turn off the stopcock and then at the right time go back to it and turn it on. Well, with the infusion pump, you can program it to, okay, at this time, deliver this much medication. And then boom, at that time, it'll give you, say I want 2 cc's of propofol to go in at this time. And you can even set those up to go, like I want those 2 cc's to be administered over 2 minutes. So it'll slowly push that plunger down until it's administered 2 cc's in those 2 minutes, or 1 cc or whatever it was. And then you got like central line or central venous catheters where they put a catheter in the patient and then it's got like either 2 or 3 ports that just hang out outside the skin. The reason we put those in is so that we don't have to keep starting new IVs on patients. Because once you put an IV in, it's usually good for about 2 to 3 days. And then you'll have clots and stuff start to form around it. And then you have to find a new vein. And the problem is you can never go distal from where you started. So like if I put an IV here in the elbow and now I need to change this one out, I can't go and put it in the hand. I have to move up in the arm or switch arms. But now see how if the patient has a prolonged hospital stay, now you're doing a lot of sticks and poking of this patient, where if they just had the one central line in, that one's sitting in, and you don't have to constantly keep changing it out and things like that and switching it. So your parts of a syringe, ooh, it was too much of a zoom. There we go. So the syringe itself is back here, right? This is your plunger piece. This is what's going inside the barrel, right? And then you have the tip of the syringe. This is where your needle, your hypodermic needle, is going to connect to. And this is called the hub. And then you have the shaft. And then you have the beveled end here. And the bevel just means that it's at like an angle. It's got like a cut to it, so it's not flat. It's got that little angle to it. And the reasoning behind that is so that you can go into a vessel and watch the point of your needle going in nice and easy. And then just slide right in. But those are your parts of the syringe and your hypodermic needle. Shrink that back down, not that much. There we go. And you're labeling them, right? It's the name of the drug, the strength that comes in. You do not have to write the expiration date on your label. These are the two things you need, name and strength. You need some kind of waterproof ink. Your skin marker does that. It has to be legible. So somebody else has to be able to read it, because what if you started the case and you're getting relieved to either go to lunch or go home for the day, and your relief comes in and they don't know what medication's in what container because they can't read the label. Try to always place your medications in the same spot, in the same area, right? Usually we keep them over by all of our countable stuff, because when we're up at the field, that's right there within our reach. We don't have to go too far on our table or anything to get it if we need it. With that being said, whenever you hand up the local at the beginning of the case and they inject, when they hand you back the syringe, you got to do a couple things. First, look at the syringe and see how much was used. Now, either write that number down, like on your back table or something like that, or remember it. How much was used? Then you're going to take the hypo needle off and you're going to refill the syringe back to 10 cc's, or, if it was a 20 cc syringe, back to 20 cc's. But you'll fill it back up to 10, get the air bubble out of it, and then put your needle back on, and then just lay it on your back table. That way, in case they need more, it's already ready. You're like, oh, hey, hey, hand me some more local. You don't have to go, oh, take the needle off, fill it up, get the air bubble out, put the needle back on. There you go. You can just go, here you go, and hand it right to them. If you're ever in doubt about a medication or whether it was labeled right, or if there's any kind of question about it, just get rid of it and get all new stuff. That is the safest thing to do. And that way we don't end up with some kind of medication error and harm the patient. And then if there is that personnel change, make sure that they, on your 1% lidocaine with EPI's right here. Here's your saline. So that way they know and they can see that there's the label on it. And then you always let them know how much has been used already, if any. And especially with the saline too, because if anesthesia needs to know how much irrigation was used, then that's part of your report to the person who's relieving you. Is that this is how much we've used so far, blah, blah, or this is how much is left, and this is how much we've used, that kind of thing. So if the question ever comes up, they have the information. So sometimes on our field, we do mix drugs. They want, like a half and half mixture of 0.5% marcaine and 1% lidocaine. Those are usually fairly easy kind of to do. If you have, a 30 cc bottle of 0.5% marcaine and a 30 cc bottle of 0.5% or 1% lidocaine, then you can just pour both bottles into the same container. And there's your 50-50 mix, 30 cc's and 30 cc's. You'll have a total of 60 cc's, but you've got that 50-50 mix. Sometimes when it's a little off, like if you have a 50 cc bottle of lidocaine, but only a 30 cc bottle of marcaine, now what do we do? Suggestion would be to pour the 50 cc bottle up first, take your 10 cc syringe and get rid of 20 cc's. Just draw up 10 cc's, squirt it out into the trash. Draw up another 10 cc's, and squirt that in the trash. And then now you can take the 30 of the marcaine, mix it with the 30 you have left of the lidocaine, and there's your 50-50. I'll show you guys kind of how to prevent getting air, especially when you're drawing up out of a vial. All it basically is just making sure that your needle is below the level of the fluid. Once your needle gets exposed to any kind of air that's in there, then you're going to be drawing up air. And I'll show you guys too how to get rid of air bubbles in your syringe. Then I'll show you guys how to pass the syringe with the needle on it. What you have to do before you give it to them is take the cap off the hypodermic needle. And I'll show you how to safely pass those sharps and things like that. And then again, you're telling them the strength or concentration and the drug that you're giving them. 1% lidocaine with it. So these are some of our routes, right? The ways that we give drugs to patients, right? We can give it intravenous or IV. Intraosseous, that means directly into the bone. We do have IV catheters that are meant to go directly into a bone, typically only done on the trauma patient when you can't get any other access. Intramuscular, a lot of you have already experienced this with all the shots and stuff you were given by Vision, right, in your shoulder. Typically, the places we give intramuscular shots are in the shoulder, in the deltoid muscle, and in the gluteus maximus. You typically want like a big muscle group area to inject into. Subcutaneous, right underneath the skin. Intradermal is right on the skin, or right still within the epidermis-dermis layer. Subcutaneous is just below the dermis. Intraspinal also can be called intrathecal, Thecal, intrathecal. You can actually get a catheter into by the spinal cord and have medication drip onto the spinal cord for numbing in that area. Intraperitoneal, that's inside the peritoneum, in the abdominal cavity. We definitely do that when we're irrigating. We pour the saline in there. Another thing, sometimes you'll see them doing what's called tap blocks for these patients. They'll inject like a local anesthesia in and around the abdominal muscles so that when the patient wakes up, especially after a laparotomy, they don't have as much pain because those muscles aren't really hurting at that point. They're under local anesthesia. We've got oral. Oral through the mouth, right? You either swallow it down into the stomach or you have it buccal, which means, I don't know, some of you have probably done this. You have a piece of like hard candy and you put it in between your cheek and your gums. That's buccal. There are certain medications that get absorbed through that mucosal membrane there, and that's where you put it, is right in between the cheek and the gum line. Um, Sublingual goes right underneath the tongue. The best example of this one is nitroglycerin for those patients that have like chest pain, angina, or like have like a blockage, slight blockage of their coronary arteries that can cause a little bit of chest pain and things like that. You take a little bit of that nitroglycerin and it helps calm that stuff down and calms down the irregular rhythm and stuff of the heart. Topical means it's going like right on top of something. Usually topical is right on the skin, but we can place things, on topical or topically on top of structures inside the body too. But an instillation, that's a mixture. That's it's a liquid. Liquid is something you drink. Right? Transdermal, that would be like a patch, like the nicotine patches, things like that. Trans means it's going through the skin. Rectal, those would be like a suppository. It looks kind of like a pill, only it kind of, once you put it up into the rectum, the body heat and everything will kind of melt it down and it'll get absorbed by the mucosal membranes of the large intestine. We have some vaginal like creams, like a Sylvadene cream and I can't think of the name of the other one, but it's kind of like a Sylvadene cream. Usually, whenever you have some kind of surgery down there, like an anterior posterior repair for like a prolapsed uterus or vaginal wall or something like that, they go in and they cut away some of the excess tissue that's in there, and then when they close it back up, it kind of tightens everything back up. But we'll put that Sylvadene cream over those little incision sites and things while they heal. Intranasally, that's that Afrin spray, right? Some of you have seen commercials for, like the allergy sprays or whatever. That Afrin's kind of the same way. What it's meant to do is, and the reason that they work and those allergy medications work is they're not necessarily attacking the allergy. That medication is making all of the blood vessels and stuff in your nose shrink up real tight so that there's no histamine and all the things that your body reacts to allergically kind of thing. It's not getting there. And the things that are coming in that would cause an allergic kind of reaction and the runny nose and the itchy eye and all that kind of stuff isn't getting into the bloodstream because those vessels are all like real tight and constricted. So that's not even getting into the bloodstream. So that's why you don't even have the reaction, is you've cut off the ability for the body, for that even to get into the body and the body to even send something there to combat it. And then an inhalant is that goes down into your lungs, usually comes from your ET tube. Those are your like desflurane, isoflurane, your anesthesia drugs that keep you asleep under general anesthesia. Some assessments we do on patients that are given, medications and things like that. We watch them. We make sure, right? We're looking for these kind of adverse reactions. And if a patient has, maybe they've never received a certain kind of medication, so they don't know if they're allergic to it or anything like that, or they don't know that it's, contraindicated for, what's going on. And then we give it to them that first time, and then we see this adverse reaction. And it could be, they get like kind of a rash, like all over their whole body. It starts to swell. It's maybe their airway starts to close off, things like that. We're watching for those things, and sometimes patients that are given like a gram of Ansef. Ansef is a antibiotic, usually given preoperatively, which means before we make the incision, as a kind of a prophylaxis. Is, hey, we know we're cutting you open. We know you might be susceptible to an infection, so we're going to give you some antibiotics to have on board just in case beforehand. I've seen some patients get ANSEF, and you see like their chest and maybe in their face kind of gets flushed and looks like like red and kind of blotchy, right? It looks like they're having some kind of reaction, and that may be something they take note of, and then let the patient know after surgery so that in the future they can say, I have like a slight reaction. I got that medication once. They told me I had like a slight reaction to it, or something like that. With the like drug allergies, over time you can run into like a hypersensitivity. You can kind of build up that problem. And then you have your different types of allergic reactions, right? Your mild and your hypersensitivities and things like that, and all the way down into the anaphylactic, which anaphylactic means like your tongue is swelling up, your airways closing off. Anaphylactic allergies are life-threatening. These are the ones where you hear about, peanut allergies and penicillin allergies and things like that, where those patients, if something happens, if they get just a whiff of it, their airway can already start closing off and things like that. So after the medication is administered, certain documentation has to take place, right? We have to say what drug we gave, what dose we gave, how much was given, what route it was given by, what time it was given by, who gave it, and what was the patient's assessment, following that administration of medication. The usually it's the nurse who's doing all this in the chart and stuff. We don't, as far as like documentation into the chart, we don't do any of that stuff. We don't write in the chart. We don't type into it. We don't, none of that. This is all the stuff that the nurse is watching for, and then the doctor talks about like in their dictation. In table 12-6 in chapter 12, there is a list of do not use abbreviations. The reason that we do not use those is that they're too easily confused for something else. And too many medication errors have come of using those abbreviations. So those are abbreviations that are off limits in the hospital, so we don't make any mistakes. Let's see, I'm going to go ahead and stop there, because as we get into the rest of these, then we're going to be talking about like some of these categories of drugs, and then a lot of the drugs that we most often use in the OR under each one of those categories. I'm sorry, hang on just 1 second. Sorry, I was talking to my daughter. Does anybody have any questions? Comments? Concern? I see now that everyone has accessed the EALs. Please continue to work on those. If it blocks you out of one chapter, jump to another chapter. Your midterm on Monday is going to cover everything we've covered so far, to include what we're doing this week and last week. Yeah, like I said, if you didn't get your assignments turned in from this past week, you have until Wednesday. For lab tomorrow, It's setups, setup, 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 setup. Time yourselves. I believe everyone in Group A was under the 20-minute mark. Yes, no workbook assignment this week. I think there is a discussion board. Yeah, your chapter 12 and 13. Let me double check it, make sure I'm saying the right things. Where's my calendar? Well, you do have an assignment. Okay. Well, that was this past week. Yeah, you have a discussion board and the HIV assessment that are due on Sunday. Other than that, no other homework for this week. We will later in the week go over what you need to study for the midterm. The midterm is 84 questions, I believe. So you'll get the whole class time on Monday to take that test. It'll be the only thing for Monday. There may be a video after, but I'll have to look to see what how many chapters we're going over. If it's only 2 chapters, then there won't be a need for a video. And I think we'll be getting into chapter 8 at that time. So I think we're going to take a couple weeks on chapter 8, because chapter 8 is, there's a lot of information in it as far as the different microbes and stuff like that. But yeah, we'll come to that when we come to that. Yeah, no workbook assignment this week. Now, if you want to be adventurous and you want to work ahead so that maybe you don't have work to do in like the last couple weeks of class, you can do that. But that's just a suggestion. It's not mandatory. All right. Has anybody got anything else for me? Questions, comments, concerns? Anybody want to fight Mr. Ortiz? Maybe not yet. I'll save that question for a couple of terms from now. I'm sure I'll get a lot more responses to that one.